So once again, thank you very much to the Society for the invitation to speak. I was asked to speak about advances in coronary intervention. There was some discussion about having a debate with Professor Taggart about PCI versus CABG and multivessel disease. To be honest, I think that's a tiny bit dull. We've done it. I first had a debate with David about that subject 10 years ago now, and a lot of the arguments are exactly the same. The data is changing, but I think most of what we would talk about, the pros and cons of PCI versus CABG and multivessel disease, are the same. So instead of that, I had a look at the session, and I've decided to talk to you about a subject that is pertinent to both surgery and PCI. And that is how we use anatomy and physiology to decide which patients need revascularization, and in particular, which lesions need revascularization.
Sorry, that's not intentional.
No, I know what you're thinking. You're thinking, I know what a significant stenosis looks like. I don't need some cardiologist to come up from Southampton to tell me. And I can understand why you think that, but the fact is that you're wrong. And if one thing comes out of this presentation, I want to convince you that you can't tell whether a stenosis is significant by looking at an angiogram. Is this right coronary artery significant? Is there any way of turning the lights down? Because the angios don't show particularly well otherwise. So this is a single coronary artery, and I defy you to know whether this is significant or not. And it is important, and I'm going to tell you why it's important. Thanks very much. If you are using the anatomy, i.e. the angiogram, to decide which patients need bypass surgery and which patients need PCI, and which vessel needs PCI and which vessel needs grafting, you're very likely barking up the wrong tree. And one of the things I want to talk about today is how we can improve on that. So here's the patient. I showed you the right coronary artery before. And the bottom two are obviously his left coronary artery. He's a man who's got slightly atypical symptoms, a bit of chest pain, not consistent, but he does get breathless on exertion. He's come to an angiogram, and this is his anatomy. And the question that I ask you is, he's got multivessel disease. Should he have stents or surgery? Now, all David's comments, of course, I disagree with about 70% of what David says, and I don't agree with his interpretation of the literature. But nevertheless, he performs an extremely important function, which is to raise very important issues about the way we all work, particularly interventional cardiologists. And the issue here is most of the people in the room, if not all, want to do the best for the patient in front of us. And how can we achieve that? Now, we're used to making decisions about revascularization, all of us are, and we're used to the MDT, and we're used to using anatomy, but we're not so used to using physiology, and I think it's very important because they are interdependent on each other. And if you are not comfortable with this concept that you can't tell from an angiogram whether to use the anatomy to decide what you do, you're a bit like these people. You've taken your eye off the ball. So let's look at some baseline facts. And I deliberately didn't want to get into a debate, but some of the things I say will obviously be very relevant to some of the points David's raised. The syntax score is an anatomical score for an accurate, objective assessment of the extent of coronary disease. There's no question about that. And I know you're having a session on this later, so I won't labour this point. If you split the patient scores into tertiles, as David has said, the score is predictive of adverse events. And as you know from the 5-year outcome data published in the Lancet, as the tertile scores get greater, there's a greater benefit from CABG versus PCI. And that was the conclusion of this Lancet paper. And I wholeheartedly agree with that conclusion. I still do. I think if you have a very high syntax score and you can have bypass surgery, then you're better off having bypass surgery, and that's the way I practice. And we're very lucky in Southampton to have excellent surgery. But obviously, when you're in an MDT and there are lots of comorbidities coming up, suddenly my surgical colleagues are saying, isn't there something you can do with a PCI here? So I think there are swings and roundabouts, and it's not a competition. That's really the thing I want to bring up. But here's where the rub starts. There's a huge body of data to suggest that the presence and extent of ischemia is what predicts adverse events. It's not the anatomy. And that slightly flies in the face of what we've just heard from the syntax score. It's likely that the extent of coronary disease correlates with the extent of ischemia. But we don't actually, in many cases, know which lesions are causing ischemia and which ones aren't. And in the field of interventional cardiology, the pressure wire has now become a very useful way, in fact a game-changing way, of deciding for the patient which lesion is ischemic and therefore which one benefits from revascularization. But that hasn't caught on quite so much in surgery. So FFR is robustly validated, highly reproducible, and excellent tool to determine whether a lesion is causing ischemia. And it can be therefore used as a sort of artificial binary arbiter for prediction of outcome in terms of MACE. And there are very high-quality randomized trials, all published in the New England Journal of Medicine, showing that, for example, if you stent a lesion that's tight but is not ischemic, it does worse than if you don't treat it apart from with optimal medical therapy. Incidentally, the FAME2 study, which has produced 2 New England Journal papers, shows unequivocally that there is benefit for PCI in terms of reducing outcome events compared to optimal medical therapy. And the final baseline fact is that the only thing that really makes what I'm going to say to you now contentious is the possibility that you will infer I'm saying that more people should have PCI who would have had CABG. I'm not interested in that whatsoever, I assure you. I want the patient to get the best treatment. If I refer a lot of my patients for CABG because I think it's an excellent treatment. I'm not interested in the rivalry. I'm interested in how we get this right. So here's our patient again with the 3-vessel disease. And the question was, should they have stents or surgery? Well, quite remarkably, if you look at FFR, the cutoff, incidentally, is 0.8. None of these lesions are ischemic. And the right therapy for this patient is almost certainly optimal medical therapy with nothing. It's scary. So our algorithm, when we see someone with chest pain, is we often look for evidence of reversible ischemia in a global way, and then we do an angiogram. And often nowadays, especially with the new NICE guidelines, we go straight for an angiogram, which I think is debatable. And then we have 3 main management options. We know a huge amount of the benefit of FFR, pressure wire, to tell us which patients should have PCI and which vessels should have PCI. But we don't know that much about how using that physiology at the diagnostic stage would help us in determining which patients should have revasc and which type of revasc, and we should be doing this more. A few years ago, I set up a study called Ripcord, which was looking at the difference that FFR being available at the diagnostic angiogram stage would have in making management plan. So basically, the hypothesis is how different would our management be if we had FFR for all the major vessels compared to just the anatomy by an angiogram. So we took 200 patients, the cardiologists who had listed them for an angiogram did the angiogram. We asked them to make a plan as they normally would, medical, PCI, CABG or more information required. They left the room, an interventional cardiologist came in and did a pressure wire of all the major vessels that were big enough to stent. And then we showed the FFR data to the original cardiologist and asked them to make a second plan with the same options. And the primary endpoint for Ripcord was the difference between the angiogram-derived plan and the FFR-derived plan. Very simple. This is an important slide. On the y-axis, we've got the FFR. Above that red dotted line, the FFR is not significant, and below it, it is ischemic. And on the y-axis, you have degrees of angiographic severity. So in these patients here, the lesions look tight, but they are not ischemic. And probably more worrying, in these ones, the lesion doesn't look tight, but it definitely is ischemic. And it's a lot of the patients, isn't it, where you can't really tell. In fact, it was 1/3 of the lesions. The cardiologists changed their mind about whether a lesion was significant in 1/3 of the lesions when they had the FFR data. It's pretty scary. And of course, this had an impact on the management plan. And I can't go through this in detail, but the management changed systematically in over 1/4 of the cases. And the interesting thing is, in this study, it's only a small pilot study, but more patients had CABG after FFR was available than before. But they were just completely different patients. That's the scary thing. Lots of people had PCI after FFR, but they were just completely different from the ones who had a PCI guided by angiography. That's why it's scary. Now, I've shown you this slide. This is from my Ripcord study, showing this discrepancy between our ability to look at the anatomy and our ability to look at the physiology to see which lesions are ischemic. But don't take a 200-patient study's word for it. This is a sub-analysis of the FAME randomized trial. It shows exactly the same degree of discrepancy. This is the famous trial which I was involved in and we published last year in the European Heart Journal in ACS patients. Exactly the same degree of discrepancy. And these are over 4,000 lesions. Exactly the same discrepancy. So one thing that you should take away from this talk is very important. It doesn't matter how experienced you are. It doesn't matter whether you're a surgeon or a cardiologist. It doesn't matter how tight the lesion looks. You will not get it right in 1/3 of cases if you think you can use the anatomy to tell whether a lesion is ischemic. That is just a fact. How does the pressure wire affect people who have bypass surgery? Well, I've been speaking to David about this. I think we need more data. There's very little data on how we could use this to determine. Imagine syntax being reproduced again, but guided by pressure wire. I'll show you some data in a minute. This is really the only proper data we have, and it's very small. These are patients who had multivessel disease and underwent bypass surgery, but they happened to have had pressure wire before. And what they did was they looked at, in the y-axis, the FFR values of the lesions that were grafted before they had grafting. On the x-axis, the graft occlusion rates a year later. And you see that where you see the cutoff of 0.8, above 0.8 pre-stenting, there's a very high rate of graft occlusion because the lesions weren't ischemic. So we could utilize this, surely, to improve the management of our patients. And the change in management, don't take the Ripcord's word for it. This is a big registry of over 1,000 patients. And on the y-axis here, you see medical, PCI, and CABG. These were the management plans of patients just based on angiograms in these 1,000 patients. And then in the coloured bars is what the final plan was after the FFR had been revealed. And you see some fascinating things. So a third of the people who were going to have medical treatment only required some kind of revascularization. Of the ones who were destined for PCI, 8% actually had bypass surgery because they had more severe disease than was originally thought. But nearly a half of the people who were destined to have PCI, as David has said, didn't need any kind of revascularization because they weren't ischemic. And of the ones who were destined to have bypass surgery, I reassure you only 13% were changed to PCI. But over a third of them didn't need any revascularization at all. So I think the days of using a diagnostic angiogram to decide anything about how a patient should be revascularized are flawed, and they should nearly be over. But how do we marry up this discrepancy between the anatomy, which is the syntax score, with the physiology that I've just been showing you? And it is possible to do that. There was this beautiful paper from Bernard de Bruyne's group. They took patients in the FAME trial, and they did a syntax score on all of the patients. And then they did the syntax score again, but they only counted lesions in the score that were ischemic on FFR, and they called that the functional syntax score. So on the left here, you see the 3 tertiles of severity based on the anatomy, and on the right, you see the functional syntax score tertiles. And what you see is in blue, there are a much higher proportion in the low syntax group, and a much higher proportion in the medium syntax group, and a much smaller proportion in the high syntax group based on ischemia. And in fact, this led to a greater predictive accuracy of subsequent events using a functional syntax score than just the anatomy. So we should surely now be incorporating physiology. And what about the future, just to finish? Well, in the future, in some patients, it will be possible to derive all this information without ever sticking a needle into anyone's artery, which is fine by me. So there's a company called HeartFlow which have developed a very clever system of using CT angiography raw data. And the quality of CT angiography in a lot of patients is now diagnostic. They take the raw data and put it through a supercomputer using various assumptions and come up with a functional FFR. And believe it or not, this works. And it has a very high degree of predictive accuracy in the studies that have been done so far compared to invasive angiography and FFR. So we're now looking at the prospect of being able to get the anatomy and the physiology in patients who are suitable for CT angiography without ever sticking a needle in them. And I think it's just incredibly exciting. There's a study called Platform being published later this year that we've been working on. And I'm presenting a late-breaking trial doing the Ripcord study again, but using a cohort of patients who only had CT angiography and FFR. We need more trials to look at the clinical utility of this, but imagine what a game changer it will be if we can have non-invasive assessment of anatomy and physiology in our patients without ever needing an angiogram at all. So in conclusion, I'm not interested particularly in debating bypass surgery versus PCI in principle. What I'm interested in is debating on whether what we're doing is the right thing for our patients. Some patients are much better off having bypass surgery, and I want them to have that. Some patients are much better off having PCI, and I want them to have that. Some patients, we're probably getting their management wrong on an industrial scale because we're not using the right tests. We need ischemia-directed management. So I want the best for my patients, and you want the best for yours. And I embrace the MDT approach, particularly for left main and multivessel disease. But I think physiological assessment is a big step forward in refining our treatment of patients. And we should embrace FFR and we should use it more. And we'll get our management right. I've just had a £1.6 million grant to run a randomised version of Ripcord, which should be a definitive trial. Now, are you ready for this to be done non-invasively? I mean, it's astonishing, but in a few years' time, I think this is the way we will be going. Thanks very much for your attention.